part and parcel of their checkup if they have not had the pap smear in the near future. So it's always advisable to use this opportunity to do a complete checkup, do a pap smear, teach them self-breast examination, talk to them about their height, weight, BMI, and other things, because the metabolic syndrome is what has. And no organ system works in isolation. What is there in the body, that is what is reflected even in the uterine and the reproductive health. So this is an ultrasound picture that we really like. A small, shrunken uterus with a volume of maybe around 5 to 7 years post-menopausal, 20 to 30 centimeter cube with an endometrium that is barely visible. A cervix that is not showing any clear mucus, and ovaries that might be visible, that might not be visible. But sometimes, especially in this era where we have master health checkups, health awareness has increased. So there are a lot of companies that pay for master health checkup for the parents. So in those master health checkups, when it is done, they're having a cardiologist, they're having an ophthalmologist looking at them. The physician is also going to look at them. And then what everyone asks is for an ultrasound. So ultrasound is written as a part and parcel of clinical examination. So this sort of picture where you see a thick endometrium is not very infrequently picked up. So what do we do about this? The woman who is quite relieved that she's rid of her periods, she has a sense of freedom, she does not have to plan her entire life based on the menstrual cycle. She can go to puja, she can go to function, she can travel, so it is not really related to that, is my period going to come? And perimenopausal AUB is a time where you don't know when it will come, how long it will last, how much it will bleed. So this is all very messy. So to add value addition when you see a thick endometrium is putting on your Doppler and seeing if there is increased vascularity all through, or do you have a single feeder. And this increases our suspicion that it is most likely a polyp, because an asymptomatic thick endometrium, which is hyperechoic with hypoechoic specs, which on if you are doing a 3D, even if you don't have a 3D, even on a 2D, it is good enough. And also what I would like is have a look at the ovaries, because sometimes we think a woman of 50 years who has not had periods for the past 5 years, she could still have a sudden increase in a single follicle. So if you have an explanation, a follicle which is most likely secreting estrogen, you can correlate with your serum estradiol level, then you have an explanation for that thick endometrium. So have a look at the ovaries. If they are looking like this without any antral follicle count, then the best thing is to do a hysteroscopy and remove it, because the endometrium and polyp, they are not like a single entity. It is like a forest with different types of trees. So some areas might be there which have atypia, which will increase her risk. So almost in 30% of cases with endometrial hyperplasia, atypias are picked up, and very rarely endometrial cancer is picked up. So it is always advisable, rather than do a SIS and then try to find out what is the cause, doing a hysteroscopy is so much more easier. And in menopausal women, doing a hysteroscopy is also easy because the rest of the endometrium is going to be bald. They're not going to have a fluid overload. So estrogen, young women in hysteroscopy have a higher chance of fluid overload than a menopausal women. That is the reason in young women also we are giving GnRH analog to make them artificially menopausal and then do a hysteroscopy. So targeted, taking it out, making sure that the cavity is clean and the rest of the endometrium is bald is what we need. So the clinical dilemmas where the assessment matters is, are they symptomatic, are they asymptomatic? In symptomatic postmenopausal bleeding, there are very clear guidelines. There are definite thresholds that say above this you definitely need a biopsy, because the chance of an abnormality being there in them is pretty high. That means there is a high pre-test probability of picking up something abnormal. So the number needed to treat will be much lesser. That means if you're doing 40, 50 endometrial biopsies, you might pick up one case of atypia or malignancy. But the whole scenario changes in an asymptomatic woman who it is an incidental finding. So we are not sure what is the clinical picture, and there are no universal consensus on threshold. And as such in them, even if they have a thick endometrium, the pre-test probability is very less. That means the chance of having an abnormality in that woman is so less that you will have to do a large number of biopsies and interventions, which we would not be doing and subjecting the woman to all that risk if she had not come to the doctor. She would have been very comfortable at home. Okay, so extrapolating the symptomatic protocols to asymptomatic is not evidence-based, and this endometrial thickness cutoff of 4 mm is not the same for asymptomatic women. It is for symptomatic women. And transvaginal ultrasound is almost every clinician's third eye, and that's what we need to do it. So the definitions are more than 12 months, no periods, she is menopausal. Symptomatic is any discharge, bleeding, or spotting. Asymptomatic is absolutely no bleeding and an incidental finding on ultrasound. And endometrial thickness, you need to measure the double layer in the sagittal at the thickest point. So, and we need to know if the woman is on HRT or tamoxifen, because there we have different endometrial physiologies. So this is a 51-year-old lady who was having irregular cycles in 2010, where she used to have 20 to 22-day cycles. And from 25, she was having 3 to 4 months. And she is 51 and she wants to basically know, when on earth am I going to have menopause? So if you see this ultrasound, you can hardly make out which is the endomyometrial junction and all that. So saying that TVS is the best is not always true, because she's had previous scars, and you can see the abdominal wall thickness, the uterus is pulled up, and here you need to do a transabdominal scan, go back and do that. So in that lady, we found that there was very little follicular activity. The estradiol is very low, the AMH is very low. So use other technologies that you need to be able to individualize what sort of treatment that she will need. So we said doing a hysteroscopy EB and inserting progesterone containing IUCD will be the best option, because she's still having periods and she's not too comfortable about that. So in an asymptomatic woman, what is the normal endometrial thickness? So how did we get these numbers? So when a vast number of women were studied, almost 2,952 asymptomatic postmenopausal women, how much is the baseline endometrial thickness? Most of them were less than 4 millimeters, some were 4 to 8, some had 8. And you can see 77% were less than 4. And the range, if you see, it is from 0.2 to 28 millimeters. So all of them were asymptomatic. So that is how this threshold of 2.9 to 3 mm came. And remember, thick endometrium is not a common normal finding in most of the postmenopausal asymptomatic women. And if we have this low cutoff, and we were almost 3,600 women were studied in 15 studies, and the endometrial cancer risk is 0.6, and atypical hyperplasia is also around 0.6, and combined premalignancy is 1.2. That is because that means you will have to do 100 biopsies at least to pick up one endometrial abnormality. So different guidelines have given 4, 4 to 5, and a 5 mm threshold. So we take these thresholds we've adapted from symptomatic women, so it's not really good for that. So in asymptomatic, so if we increase the threshold to 6, the sensitivity drops, but the specificity is pretty high. That means a negative predictive value does not say, because it's a low prevalence, it does not say that the test is excellent. It says you're doing the test in a group which has a low pre-test probability. And as you can see, shifting the endometrial thickness makes it a higher endometrial thickness, makes it more specific. And these are the different cutoffs, and so I think use what works in your women. It also needs to be personalized. And what is most important is if we take an endometrial thickness of more than 10 and say even if the person is asymptomatic at 10 mm, I'm going to intervene, we would be picking up 16% positive cases. And when it was less than 10, in this study of 267 people, which was published very recently, they did not have a single case of endometrial cancer. And these are what all the meta-analysis are telling us. So maybe 5 mm is too low for asymptomatic women, 10 to 11 mm might be a reasonable trigger, but based on the patient risk factors, we have to individualize. This is one lady who is 55, attained menopause 6 years ago, now having postmenopausal bleeding, on and off spotting, and an ultrasound you can see there is fluid collection, there are internal echoes, and there are small fibroids, and those fibroids are pretty vascular. So these are the women who we missed out in the perimenopausal checkups and who sometimes land up as postmenopausal bleeding. So what we need to see is whenever they are obese, whenever they have diabetes, and one of the risk factors was shown was all hypertensive seem to be having more endometrial pathologies. So hypertension is not just a systemic disorder, it is a reflection of the aging. I'm just done. So you need to look at the morphology, vascularity, and other signs like particulate matter, irregular endomyometrial junction, interrupted junctional zone. And you can see these are typical with cystic spaces where we ask for a biopsy, look at the vascularity, look at the ovarian function. So the practical algorithm is if it is an incidental finding on TVS, less than 5 mm, reassure them. 5 to 10, do they have risk factors? If it is more than 10, do a hysteroscopy and biopsy. And individualization of care is the most important thing. Thank you very much.